Greetings to all of you from around the world. We have close on 800 people registered for today's event, so I hope it is going to be one that you're going to enjoy. I'm Dr. Karen Michell. I'm the Research Program Lead for Occupational Health here at IOSH, and I also serve as the Chair for the Scientific Committee on Accident Prevention, which is a committee of ICOH. It is my pleasure to welcome you to this second webinar. We hosted our first one in September last year as an introduction. So for those who did not see it, you can go to the IOSH website and you'd be able to access the recording of that. Today, we are joined by three panelists, two of which have joined us. One, Dr. Jain from India, may be struggling to make connections, so I'm hoping he's going to link up with us just now. But by way of introduction, I'd like to introduce, first of all, Dr. Odette Volmink. She is a medical doctor and an occupational medical specialist based at the National Institute for Occupational Health in South Africa. She worked in clinical practice in both hospital and urban settings and rural settings in South Africa before practicing medicine in the United Kingdom, where she developed her passion for occupational health in Scotland. On returning to South Africa, she completed her residency at the University of Witwatersrand, obtained her master's in medicine, and successfully completed her fellowship in occupational medicine. She has more than 10 years experience working as an occupational medical specialist at IOH, where she has both clinical, teaching, and research role in the occupational medicine department. Greetings and welcome, Dr. Volmink. Then we are also very fortunate to have with us today, and I see he has just managed to link, Dr. Rajiv Jain, who is a well-qualified medical doctor with additional qualifications in community health administration, including hospital administration, as well as in Chinese languages. He has more than 40 years experience in health and hospital administration. His particular interests include One Health, environment and health, disaster management, pandemic management, hospital accreditation, quality and regulation in healthcare, health administration, including hospital, as well as education and training and infectious diseases. Dr. Jain is the Senior Advisor, One Health and Neglected Tropical Diseases Foundation for People-Centric Health Systems. He is also the chair of another scientific committee within occupational health, and that is the Committee for Education and Training in Occupational Health. Dr. Jain, welcome. Then our third panelist today is Alex Wilson. Alex is a passionate occupational hygienist who has 20 years experience in the field working in various sectors. His current role of group hygiene, industrial hygiene and occupational health manager at Johnson Matthey gives him a wide supporting role assisting the business in implementing good health risk management practice throughout the global workforce. Alex holds a first class BSc in Environmental Science, majoring in Occupational Hygiene from the University of Bradford, and an MSc in Workplace Health from the University of Nottingham. He is a chartered member of the Faculty of Occupational Hygiene. Alex also takes his profession very seriously. He is currently the president of the British Occupational Hygiene Society. He is married to Sarah. They have two sons with whom they enjoy camping, walking, mountain biking, and exploring, as well as playing numerous sports, eating good quality food, and binging on films and good TV. Good to see that work-life balance there, Alex.
Thanks, Kevin. Hi, everyone.
To all our panelists, a hearty welcome. I just want to start off by setting the scene today. The first thing that I want to note is this is a joint event between ICOH and IOSH, and proudly we are able to say that we have two of the scientific committees represented here today, SCAP and Education and Training. Please, next slide, please. Just as a way of introduction, this is a very quick introduction to what the mission of the two organizations are, and it is my pride to say that both ICOH and IOSH work towards the well-being and providing a safe working environment for the workers in our global working population. Next slide. In 2021, the WHO and the ILO published the first joint report on the global burden of disease. And what was very alarming from that report was that the majority of the burden of death and disability is no longer coming from accidents in the workplace, but it is coming from disease. According to their statistics, in 2016, 81% of deaths in the occupational sector were caused by disease, and that accounts for more than 1.5 million deaths. It was very clear from our first webinar that the adverse health-related events are poorly managed within the working environment, and a number of reasons were identified for that, some of which are listed. It is evident that action is necessary to understand the cause of these diseases in the workplace and take preventative action to reduce them. Failure to do so is going to result in our continuing to see an increased incidence of disease-related burden moving into the future. So, with that in mind, today's webinar is going to focus on the fact that there are many models of investigating accidents in the workplace. When you Google how to investigate a health-related event, you don't have as much good fortune. And one of the things I want to say from the outset is the fact that there are many modules. We are not saying one in particular works, but what we are going to do today is look at what are the unique things that need to be done to ensure that when you're investigating a health-related event, that you're actually getting to the root of the problem. So with that in mind, I'd like to ask our first panelist if she wouldn't mind providing us with some insight. And my question to you would be, what do you see as the challenges to investigating an adverse event in the workplace? Thank you, Odette.
Thanks, Karen. I think what you said there about the death rates due to occupational disease is quite alarming. And, you know, not only the deaths, there's about 1.6 million cases, they say, of occupational disease. And I guess it contributes to not only human suffering and economic losses because of poor productivity and decreased work capability. But, you know, I think at the core of the problem, one of the biggest challenges is that it's so much harder to diagnose and to investigate occupational diseases as compared to occupational accidents, which seem obvious, and it's just the natural response that you then would go on and investigate. So that's one of the biggest problems. And I think that, you know, it's conditions that are underreported, occupational diseases, and even where, you know, we do need to, by legislation, report these to the compensation funds, and if there are surveillance systems in countries that are set up to record, you know, all the occupational diseases, it's just the tip of the iceberg, really, the ones that are recorded.
Yeah.
Not only are there problems with regards to, you know, just reporting them, but there's lots of problems with regards to even just diagnosing a disease as an occupational or work-related disease. And you know, in terms of, you know, there's definitely inadequate training at medical schools, undergraduate medical degrees, on how to recognize effectively an occupational disease, because the healthcare worker would have to have quite a high level of suspicion in order to go the route and be able to attribute the disease to a workplace exposure or working condition in the workplace. And, you know, in order for us to do this, especially in resource-challenged situations where you have, in the public health system, you have to get through 1,000,001 patients, it becomes difficult to take a comprehensive work-related history. You know, having a good occupational history is necessary for us to make that link between occupation and the disease. And it, it entails not only taking a good history of the exposures that the patient is exposed to in the workplace, the current exposures, the work processes, the working conditions, what controls are involved in the workplace, but also, past occupational histories are just as important. And, another problem comes in is that many occupational diseases, many common diseases are very similar to, occupational diseases. So common diseases that occur in the community setting. So one example of this could be like in the setting of South African setting, we have a high tuberculosis endemic in our country. And so when a patient goes to a healthcare setting, our healthcare workers can very accurately and competently diagnose and treat tuberculosis. But then, if this is a case where it's a 32-year-old, maybe gold miner who's worked for the past 10 years as a rock drill operator underground, who is now presenting with this condition, just by them being exposed to silica dust in the workplace, makes that TB an occupational disease. And so creating the link between the diagnosis and the occupational exposure, and thereby making it an occupational disease, is critical. And this entails taking quite a comprehensive history from the patient, also being aware that there is a link between silica exposure and tuberculosis. And I think another problem also comes in terms of diagnosing these diseases, is that oftentimes there's quite a long latency period between when somebody is exposed to the exposures, the attributable exposures in the workplace, and when someone actually develops the signs and symptoms of the disease. And, oftentimes a good example is in occupational asthmas, or rather occupational cancers even, and mesothelioma, where patients only after maybe 40 years are then presenting with the condition. So these are some of the challenges with regards to diagnosis, with regards to reporting. But I think also there's that inequitable dynamic between a worker and the employer that also sometimes comes into play. And patients, even if they suspect that maybe their condition is caused by their workplace substances, sometimes are not empowered enough to be able to alert the employer to this, for fear of losing their jobs. And then, I think lastly, most countries have legislation that when you diagnose an occupational disease, you need to report it and there needs to be an investigation done. However, the regulators often don't inspect and audit that this is actually done, and if it's done, is it done effectively?
Wow, and I really like your insight there. Can I just go straight to Dr. Jain here? Because one of the things that I want to ask, and I think has become very clear from what Odette is sharing with us, is that in order to identify an occupational disease, there's all this occupational insight that you need, the occupational history, etc. So I'd like to ask you, if, for example, there is no occupational medical practitioner or no occupational health nurse on site, how then would professionals on site identify that a worker potentially has an occupational disease, or even the beginning of a disease that is caused or aggravated by the workplace?
Well, thank you, Dr. Karen, for asking this important but vital question. And that is the development that we need to have all across the deprived communities, especially small and medium enterprises or micro enterprises, or enterprises which operate from homes also. They need to have that connection with the primary healthcare system, and also primary healthcare system providers need to be aware that occupational health is one of the basic responsibilities of primary healthcare providers. Also, the owners, the people who do not have the resources to detect or manage adverse health events, they need to have the awareness that where they can access those resources. So the two dimensions need to be taken together. The basic occupational health services model, that is the BOHS model, which was enunciated by World Health Organization, and IOSH as well as ICOH has been supporting that model, because in most of the developing countries, as you know, like in India, which is such a large country, like a continent, 92% of the organizations are outside the organized system. The organizations which are outside the organization organized system of employment, they need to have that awareness as well as provision of basic occupational health services, where occupational health is integrated with the provision of primary healthcare services. One example that we have in India and that is being rolled out across the country is development of 150,000 wellness centers, where a community health nurse or the community health provider is exposed to the possible occupational health risks that the community of say 5,000 or 10,000 may be exposed. So these individuals or the community health provider are then linked to the primary health care provider who is a qualified doctor. Then in turn, they are are being linked with the occupational health services across the districts and then across the nation, where investigative facilities and provision of care and follow-up and investigation of the incidents could happen. Because unless this is done, we would never know what new exposures are coming, how large populations are getting exposed to similar risks, and how adverse health events are rolling out across the geographies through different terrains. Another important thing which we need to understand is to have a robust information technology base behind this interaction, where the community health nurse, the primary healthcare provider are able to interact on a dynamic basis with the occupational health services, whether they are the primary level or the secondary level, or the investigation facilities are integrated there. The IT backbone provides a vital base, not only for collecting the data, but also analyzing the data and then interneting this with the National Institute of Occupational Health and the Medical Council for research, where data is collated and further hypothesis and investigations and groundwork is done to investigate further. Because unless this is done, we will never know how, in fact, for example, climate is happening, climate is having its effect on the occupational health services. So this, especially in our country, especially in Africa as well, these are primary requirements, because we are going through a transition phase where major industries are in the unorganized sector. And gradually formalization of employment is happening over a period of time. But the pace is very diverse across even one country and also across the continents. So it's vitally important that we in our countries, our governments, our civil society organizations, and our economy as such, undertake this process of strengthening the provision of basic occupational health services along with the primary healthcare services. The integrated model is the only solution to understand how to actually detect adverse health events on a large scale and on a continuing basis. Yeah. One-off approach will not work in this area. So that is the point I wanted to make at this juncture. Further discussion will happen as we go along. Yeah. Thank you, Dr. Karen. Yeah.
And I completely agree with you. I think that is one of the shortcomings, is the fact that where there are no services on site and a worker, for example, goes to his local clinic and he presents, and an adult onset asthma diagnosis is made, that nobody is then questioning, well, where does this come from? What has caused that? But so I absolutely agree with you that there's got to be better collaboration. And this is where I want to bring Alex in, because I think going back to the workplace, in my experience, an employer is generally more inclined to employ a safety professional before they would, for example, employ a health professional. And I must admit, my experience in Africa, often your hygiene facilities are what we term outsourced. So I'd like to ask, from your perspective, if we go back to the workplace and we want to look at investigating these adverse health events in the workplace, what kind of steps would you recommend to professionals who want to try and get this done in a more effective manner?
Karen, no, thank you. So I think you mentioned right at the start of the webinar that there's lots and lots of models, isn't there, and lots of methods and approaches to use. So there isn't a silver bullet that fixes everything, but the piece that I think I would very much like to kind of champion is that there's not one group of people who can also provide this work with regards to investigation. So in terms of who you involve and how you do this work, this has to be very much a multidisciplined approach, really. Depending on your workplace and depending on what health and safety or occupational safety and health professionals you may have available to you in-house, might determine the kind of approach. But if you are lacking certain skills and expertise, I would very much support that you reach out to third parties who can offer support in this area as well. And the Dr. Volmink also talked about the fact that some of these occupational illnesses have a significant long latency period behind them. And this isn't something that first appears a week after exposure and we can deal with a very quick 5 whys and all get sorted and we all go back and we're very happy with it. But this can be something which is multiple exposures over a significant period of time. So to have the right information is very, very important. And that's really what I'm aiming at. So I see from my side of it as an occupational or industrial hygienist, we have a very niche role to play, but it's a role that's important. If you want to complete the process, we need to go back to the risk assessment. We need to go back to understanding the hazards and reviewing the control measures that were part of that operator or that employee's workplace, and be that actually in the current workplace, but it could also be multiple past workplaces as well. And that might be where you have to bring in that support from previous employers to do that. So having the full scope of information available to you can help create a better picture and a bigger picture of how exposure has occurred, what potential failures has happened, and how can this ill health have actually kind of has come to show itself. Obviously, the piece with regards to health surveillance is an absolute must, which feeds out of the previous work that other professionals do. So the general risk assessments, the chemical exposure risk assessments, the validation of control measures through occupational exposure monitoring, all help create a risk register, health surveillance registers, and that can lead through to the valuable essence of what the health surveillance can help identify. If that does identify ill health, then we've got that full piece of information that can allow us to pull on this on whichever parts with the relevant piece, with the relevant experts, in order to help with that investigation piece.
And I think that's vitally important. And I think, again, one of my examples, and this kind of brings in something Dr. Jain was saying just now, is that with new exposures, I mean, I'm just talking, for example, with chemical exposures, that there are many chemicals, for example, that are now on the market that we still don't have information about. but understanding when something new is being introduced, that there's got to be an element of suspicion, and getting occupational hygienists, for example, involved, so we get a better understanding of what we should be doing. I just want to very, very quickly, we had a question come up on the board that somebody's want to know what is one of the most common occupational diseases that we're seeing in the workplace. And I just want to answer this now, just so that we can contextualize it for other members in the audience. Can I ask you within the panel, what are the most common occupational diseases that you are possibly seeing in your workplaces? Dr. Jain, I don't know if you want to answer that one.
Yes, sure. One of the most common problems that is happening in the occupational medicine sphere in a country like India is psychosocial impact of occupations. Because of economic development or deceleration of the economy, people have to work longer and they rest less, as well as there's competition to retain the jobs. So mental health challenges are becoming important. Second are the musculoskeletal disorders of various kinds, which were what we had seen pre-pandemic. We are seeing a more diverse range of musculoskeletal disorders. The third is could be classified as long COVID, kind of respiratory illnesses, which were not that prevalent, and combined with diabetes, long COVID is becoming an important entity in our practice. So these three, and of course, Dr. Odette had mentioned about tuberculosis, and tuberculosis remains a ubiquitous entity which cannot be actually neglected. It's almost to be classified as occupational disease, because it becomes a marker for other occupational disease, especially if the profession involves handling silica. So silicosis and tuberculosis go together in our part of the country. So these are the four bigger groups, I would say, and there are minor, of course, dermatological manifestation are there because of contact with the chemicals. The chemical dermatitis is also important. Then industries which have a lot of machinery, that noise-induced hearing loss is an important entity, but not that frequent, because our part of the world has more of unorganized sector work. So noise is less, but in order of frequency, I mentioned four groups: psychosocial, like psychological disorders, stress, anxiety, insomnia. So that is number one. And second, of course, I mentioned, and of course, the way things are happening, respiratory illnesses are now, so they may appear as acute bronchitis or chronic bronchitis, but actually they are part of the long COVID phenomenon.
Thank you. Odette, are there any specifically that you're seeing in Africa?
You know, I must say it's very similar. It's very similar to what Dr. Rajiv Kumar has said, in terms of we still see a lot of noise-induced hearing loss. Sadly, we still don't have that under control, but definitely, we are struggling. We don't even know the mental health issues that are out there. We're just seeing the tip of the iceberg, but it's growing, since the pandemic. Definitely is an issue in musculoskeletal disorders.
Right. Alex, with your work, are there any in particular that you're being aware of?
So as well as ones that people have mentioned already, I think obviously as occupational hygienists, we tend to focus more on what you'd probably call the traditional occupational illnesses. But that doesn't mean that we can't be aware of how they all link together. And some of those that there's been a lot of work on recently is the link of noise-induced hearing loss and mental fatigue and mental stress, actually. That's something which is quite an interesting area in terms of how they impact each other. But there's a lot of the news still circulates around respiratory disease, COPD caused by exposure to known hazardous substances, as just popped up, there you go on the chat, silica exposures in construction sector. My colleagues in Australia at the moment are working really, really hard with regards to engineered stone and silica exposure. Massive issue there with regards to people in their 30s dying of silicosis because they've been cutting these stone worktops in people's kitchens all their lives. So it's some of the old traditional exposures are still up there in terms of the ones that are actually causing death. And I don't want to draw anything against the ones that don't, because actually occupational disease that doesn't cause death causes significant distress, and actually sometimes that's worse. And we get that with noise. I'm a big noise advocate. I support kind of good hearing conservation, and yeah, noise-induced hearing loss doesn't really kill you, does it? It's not like asbestosis or mesothelioma, but it can provide that employee or that person with significant problems in their long-term life. So yeah, some of the traditional ones are still out there, but we need to wake up to the links between some of the ones that we see as probably slightly new kids on the block that we're finding out more and more about every day.
Yeah. I think the message is that wherever you are in the world, you need to understand that your circumstances are going to be different, and you need to be aware of what are the diseases that are being reported within your national environment. And one of the things that I just want to add here is then I think you need to do the research and understand what would you expect as a health outcome to be associated with those diseases, so that you possibly could be identifying these a lot earlier. So I want to jump in here to another question that's been asked, and I think it's very pertinent at this stage, because we're talking about the latency period. We're talking about the fact that so many of the signs and symptoms are similar to common conditions. You know, a lot of them start off and you think, oh, somebody might have a cold, for example. So one of the questions is, how do we determine when a health event or a chronic condition is work-related or being aggravated by the workplace? Odette, would you like to take this one?
Sure. So you're asking when is it necessary when should we be alert to it?
Yeah, so when, for example, is asthma possibly occupational aggravated asthma?
Okay, I think it depends on which role you're playing. I think, as a medical practitioner, you would need to find out a little bit more about the condition. We like to find out, when did it start? The timing, did it start a little bit after you were exposed to the condition? Maybe you were exposed and there's a little bit of a latency period, and then you develop the condition. So getting a nice idea of the onset of disease is important. But then also, how is this disease presenting, or how are your symptoms presenting? Particularly like asthma, that it has a particular, especially in the beginning, a work-related pattern. So you would find out information about, are you getting a chest? Are you getting some chest tightness, some cough, whatever symptoms that are most predominant? Is it related to your work? Is it worse when you are at work? Does it improve when you are at home? How is it when you're on holidays? How is it when you are, over the weekends? Just to try and see if you can make if there's a work-related pattern to the symptoms that somebody's presenting with. And then, from there, it's important, even just to find out the tasks that person does. So if maybe when he goes past the spray painting booth in his automobile industry, that's when his chest is becoming tight. You know, it allows us to make that link a little bit more with what exposures could potentially be causing his condition. So getting all that information is quite critical. I think it's also important to, you know, just to have a sense of, are other people also complaining about similar symptoms in the workplace? Because, you know, this also does alert us to the fact that maybe something's going on, and maybe we need to investigate this a little bit more and investigate, you know, particular work exposures that could cause these conditions a little bit more. So I think just getting all that information is important, you know, having SDSs at your disposal, just to try to see what are the potential health effects of whatever hazardous substance a person is exposed to in the workplace, to see if whether or not we could relate it to. And then I think just having, you know, looking at the body of literature around the exposures and the potential of them to cause whatever that person is diagnosed with in the workplace is vital for us making those diagnoses.
Would anybody like to add anything else to what was a very eloquent response?
Well, Dr. Odette had mentioned a lot, but I feel having a high index of suspicion is the first hallmark for relating whether a particular clinical episode in an individual could be occupational. Second, if a number of individuals in a workplace suffer from similar illnesses. Third, your linkage with the local disease surveillance system would be very useful in a geographical area, or where people from a particular workplace reside and work in a particular geographical area. The disease surveillance system will also throw red flags. And if you are practicing in the same area, you would see a cluster of cases if it is occupational. Another useful index which I've been using is taking the pre-employment history. Whether the person was having, you give an example of asthma, whether the same person was having asthma during childhood, or any history of nebulization, or any history of asthma in the family. So that gives a red signal that if nobody is having and he is having after employment, and that gets worsened after going to the workplace, and he requires more frequent nebulization or oxygen therapy, and it disables him, it is definitely it's asked me to raise further investigation, to order specific workplace, and of course take the help of occupational hygienist, and a collaborative approach with the safety professional in the workplace. The three together, and the worker himself will throw up that will almost establish that this is an occupational disease, especially a disease like occupational asthma. And this goes across, many clinical entities are they present to you as normal clinical entities, and one never suspects that they could be occupational. So a high index of suspicion would help a lot. An open approach to discussion and taking help of safety professional and occupational hygienists work wonders. In my experience, I found collaborating with the local population, especially local health service, and in the workplace, occupational hygienist and the safety professional, and the workers. And at times, I've taken help of the union representatives. Sometimes throw up very good hypothesis, which we need to investigate. And I've found through my experience that information becomes very vital to actually understand, because those people are actually working with a number of workers, and they hear them a lot on day-to-day basis, and they provide very important clues to our diagnosis. Yeah, that's what I wanted to say, actually.
Thank you very much. I think that's very important. I think a number of the comments in the chats are also talking about, pre-employment, pre-placement, health assessments, and actually understanding, where workers are at before they start employment. Alex, I want to ask you something, because our other two speakers are obviously medically based, and I was going to say, one of the things that is often said to me is that from a non-medical professional, they say, well, they are very challenged because there's all this confidentiality around health. Do you have any advice to non-medical people and how they can be involved when they've got this fear that patient confidentiality prevents them from getting involved?
Yeah, no, it's a good one. I always used to have a rule that no hygienist should put the name of an employee in a report, because then we wouldn't have that problem. And I think it's a good one. And I mentioned earlier that there's a lot of data out there, and it doesn't have to be personal data to help us make decisions. And one of the things, a term that we often use in the workplace, that hygienists, and I know it's used throughout occupational health and safety, is the term similar exposure group. So we can determine, and this is where, again, we can pull information together to help determine if something is work-related by looking at data, exposure data. That could be for noise, it could be for other physical agents, chemical agents, you name it. So we can look at exposure data for similar exposure groups. It might not be for that actual individual, but it could be for individuals that that person works with, or in job roles that are very, very similar to the individual that actually has the adverse effect. And using that data, which isn't personal medical data, this is exposure data, which most countries require us to keep for a significant amount of time, can provide us with such an extra wealth of information to help make those risk-based, data-driven decisions to determine a work-related exposure, or whether the work exposure is a significant contributor to the adverse health effect. I think noise is a fantastic example of that. We had, I remember my first place of work in the steel industry, we had 10% of our apprentice new starters were coming into the workplace between 16 and 18 years old with noise-induced hearing loss. And that was at the time when the iPod just all of a sudden exploded onto the market, and nightclubs and the rest of it. And all of a sudden you've got people coming into the workplace that already have significant signs of noise-induced hearing loss, but you can have workplace data that shows that the primary cause isn't just a workplace, it's just a partial contributor to the wider thing. So I think being able to use similar exposure groups, being able to use risk assessments to help with that, it is an important piece. I just wanted to pick up on one thing that somebody put in the Q&A as well. It says, when a diagnosed occupational disease, when we diagnose that, it's too late. And I totally agree. I totally agree. And that's one of the things that we always try and push in the profession, in the BOHS and the world of occupational hygiene, is the prevention method. To prevent is the best option, isn't it? Unfortunately, we're humans and we always fail. So if an unfortunate event does happen like this, then we use it to learn from it, to then make the most of it so we can prevent further ill health from happening. And I think that's also a great example of using a multidisciplinary approach in order to get that done.
I think that is so important. I'd also picked up on that post, and I was going to comment that it's one of the the fact that the diagnosis of an occupational disease is too late is one of the reasons that we've been doing these webinars. But I think for me, one of the important things is, and I have a great case study that, if you'll forgive me, I'll quickly share, that it's this ability to collaborate better and identify early that things are going wrong. And just by way of example, we had an occupational health nurse who came to me as an occupational health and safety consultant and said, I don't know why, but I've got 9 workers who now have dermatitis who never had dermatitis before. And it was that communication coming to us, you know, as a team of workers that said, well, we need to try and understand why. And you know, the hygienist then got involved and did the air monitoring and et cetera for us, and the safety team got involved. And we eventually found out that what had happened was a new product was being made. It hadn't been mentioned to us. And one of the chemicals used in the process was causing the dermatitis. And because we got in early, we're able to go in, sort things out. I mean, we made some engineering changes, we made some PPE changes. All 9 of those workers eventually regained full health and did not go on to develop chronic conditions. And I think those are the examples of where it works well, that when you have a team working together, you can do exactly that, prevent occupational disease, which ultimately, you know, is what we're looking for. But Alex, you mentioned about the noise, and I think there's a question that's come in that I think many of us often ask, and it's just, when is noise-induced hearing loss work-related, and when is it not work-related? So it's a case of, you know, how would a practitioner know the difference between the two?
Yeah, well, I'm possibly not the most qualified to answer that question, but all I would say is that this is where we have to be intelligent customers to our data and go back to the data source. So the health surveillance will help identify noise-induced hearing loss, be that, as you said there, be that pre-employment, initial screening, or as part of annual or periodic audiology or otoacoustic emission testing, you name it. There's so much out there that can help us identify that. In terms of trying to determine whether it's work-related or not work-related, that has to go back to, well, how can we can look at it in different ways. We can look at it as a bit of a judge and a jury. How can we prove that we're innocent or guilty? Or how can we try and investigate it so we can be a little bit more like Sherlock Holmes and investigate it to determine, well, what data does exist? We have no control over data from our exposures from outside the workplace. But we do have some control with regards to understanding exposures in the workplace, and having good noise data, good dosimetry, noise mapping, and good understanding of people's daily exposures can help us show that, again, a single person or a similar exposure group can help us define that that working group as being a high, medium, or low risk in terms of exposure to noise. And again, an individual, so the question was about after hours DJ. So again, we can't say to them, well, you shouldn't do that, or you should wear hearing protection. That's their personal choice. We can advise them and educate. But at the workplace, if we know that somebody is at risk of noise, we can put those controls in place. We then have a body of evidence, which is the data, that can then go to, as part of the investigation, to say, we believe this person does have noise-induced hearing loss, but this data shows that that there's control in place, or that the noise is low enough that we don't think it's a contributing factor. Again, it's hard to actually put sometimes a definite place on it, but that using good data is a way of helping us define if something is work-related or not. And as Dr. Jain said earlier, there's a lot of things that are very hard to do that. Noise is probably one that's a little bit easier than others. But again, depending on types of substances or other hazards, there is the data out there that can help us do that. So,
yeah. And I think, for example, with things like chemical exposures, the ability to remove the worker from exposures and monitor their health when they're not being exposed at work are also ways that we can help with that. But Odette, I want to pose a question to you, which I think is also very interesting. How do we achieve transparency and credibility when we are reporting that occupational disease in the investigation report?
So is that back to me?
Well, I was wondering if Odette
Okay, cool.
maybe wants to, or I mean, either of you.
That's fine. Go on, Odette, you could go.
You know, like you said a little bit earlier, that, you know, this is confidential medical information. And so we do actually have to be very careful with how we use it. And, you know, Alex mentioned earlier that, you know, even when it may be the sentinel event that precipitates an investigation in the workplace, but names don't need to be mentioned, because it's important to, you know, have create an environment in the workplace that sort of fosters employees to be able to come to you, particularly as a health practitioner, but I think as any kind of occupational health and safety professional in the workplace, and know that, you know, their medical information is going to be treated confidentially, and you know, it allows them to continue to disclose when they need to disclose. So I think it's important, and you know, if it is vital for their information to be released, or specifics to be released, you know, things like consent and informed consent need to definitely be part of your practice, in order to ensure that you ethically managing the information that's given to you. I think that's important.
Dr. Jain, can I ask you, how do you recommend the information is handled when you know the exposures for a particular worker are such that, you know, if he continues to be exposed, you can just see this getting worse? How would you then present that information to the employer to try and get them out of that exposure?
Interesting proposition to actually engage with all the individuals at the workplace. And I feel the tripartite approach works wonders. The employee, the employer, and the colleagues, that is the unions, help to actually underscore the importance of actually ensuring that the information is taken in the right context, and ongoing intervention happens on a regular basis. What I have found is, if you are a regular visitor to the workplace and you have friendship with the workers unions, as well as the supervisors and the people who are actually owning the workplace, over a long period of time, I found them more than willing to help out in managing occupational health risks and adverse health events that happen. Wherever I found the individuals are not secure or safe, they may be compelled to work due to some circumstances, but where the unions are not organized, I found that the management of occupational disease more difficult. And another problem that we have faced, and which have been tried to be circumvented in an unorganized sector, is having a group of small enterprises owners and representatives of the workers, and then have half-a-day workshop with them on allowing them to express their views about these issues, and how it actually saves money and more income happens if they look after their health. And at this juncture, I would like to bring in the concept of wellness. What we do is bring in wellness workshops where local representatives, local workers, as well as local unorganized sector owners, they come together in a group of say 25-30 individuals, and a free run is given to them to talk about what could be done to ensure wellness at a higher level. And that pays off when actually deviation from wellness happens and they need some action. That works two ways. I get more information at an early stage, number one. Number two, they're willing to participate in the process reversal. So these two steps, which I feel they are difficult to work on, but they pay off so well in the long run, that I found that there should be more diffusion of these practices, where more engagement of occupational health professionals and safety professionals with the workers' representatives and the owners happens on an ongoing basis. Even if it happens once in 3 months, say 4 times in a year, it is more than sufficient to actually build the confidence that actually you are for their welfare, and not only their welfare, you are looking after the wellness part of it, not only the disease part of it, which I feel is a sheet anchor for communicating the right message, that we are partners in their health and wellness, not only disease management part of it. And the more confidence I generate in the wellness domain, I get more than paid off in the disease management. That becomes less of a pain point.
Right. So I can't believe it. Our hour is almost over. So what I'd like to ask each of you, and I think let's start with Alex. Alex, if there's one key take-home message that you'd like our audience to take from you, especially as a hygienist today, what would that be?
I'd say first, always make sure you're unmuted. No, I would say, as someone who, we struggle sometimes to get heard in the workplace. So I just encourage people to reach out and make sure that you utilize the resources and expertise that's available. So I do not pertain to be a doctor or an occupational health professional. I have a fantastic occupational health professional that I work with, and it's about working together. So multidisciplinary approach is definitely the one for me. Plus prevention. I always go for prevention.
Odette?
I think Dr. Rajiv Kumar said it so nicely. Always be suspicious, of these things. Just try to see, is there a link to workplace exposures? I think that's critical, and also just foster in workplaces an environment where people are easily share ideas about how to improve health and safety. And I think also, lastly, just have good referral pathways, establish what's available around you, especially where there's no occupational medicine or occupational health input. Just have a nice referral pathway, or people's brains that you can pick, advice that you can get, because it is about, it's a multidisciplinary function that we have.
Thank you. And Dr. Jain, from your point of view?
Yeah, sure. Odette has put it very well, and of course Alex, and that there's no doubt that we need to have an open, collaborative approach and remain focused on, instead of detecting diseases, managing wellness first, and of course ensuring that the first red flags are caught early, investigated thoroughly with an open mind. And Sherlock Holmes is a good example. Investigate thoroughly, reach to the clues fast, and also ensure that the team works to the focused area of ensuring that not only exposures are detected, not only diseases are detected, but that are rolled in to ensure preventive strategy for future. So it becomes a comprehensive approach from wellness to management of exposures, as well as ensuring that management of diseases are taken in a comprehensive way. That, I feel, is the most important take-home message from today's discussion. Thank you for organizing actually this event, because this is more important, not only to understand, but how to manage. And that becomes a challenge. The kind of comments that I'm seeing, I feel there is an intense interest in the area.
Yeah.
And IOSH and ICOH have taken up this area. And this is all the more important that Scientific Committee on Accident Prevention has taken up this issue on behalf of ICOH and IOSH. What could be better collaboration than IOSH and ICOH together?
Yeah.
They focus their attention to accident prevention.
Yep. So with that said, I want to thank all of you for your participation today. You have been a fantastic panel. The time has absolutely flown past. And I want to reiterate with what one of our participants said. Diagnosis of occupational disease is too late. And we collaboratively need to work to make sure that we turn those diagnoses around and we're not seeing them. We're providing workers with much safer and healthier workplaces so that we have longevity of workers and we can help them age more healthily. So to all of you and to our delegates who attended today, thank you very much. And hopefully we'll all meet again in the not too distant future. Thank you all.